Hello and welcome and greetings to all my fellow dental professionals. Talking about what improving the quality of referrals looks like. Now you would think that it was obvious how to send a referral, and I may be talking to a very diligent group today who may know all that I'm going to say about referrals. But when I started putting this lecture together, I was staggered at just how different all the systems were across the region, and also how poor some of the referrals that were being sent in. So who am I? I'm Dr. Nadeem Tony Ahmed. I'm the chair of the local dental network for Shropshire and Staffordshire, and I will lay my cards out on the table and say, why am I giving this lecture? Well, I was one of the people that really promoted and encouraged the move over to the dental e-referral system, helped with the algorithms and provided training on REGO. I'm not an expert on FDS, which is one of the other providers in the Midlands region, but I am a referrer and a provider. So I sort of see it from both ends as somebody who sends referrals and receives referral, because I'm a tier 2 orthodontic provider as well. So who am I? Well, using the e-referral service, I am a performer and a provider. As well as that, I attend all the MCN meetings for all the specialties to assess the pathways and make changes. So I can see it from both ends. Now, the portal does look a little bit different, so that's why it's important to have an idea of what both ends feels like, because the sender portal and the receiver portal are different. And again, the hospital tier 3 providers also have their own portal, which again looks slightly different again. Now, I was part of the group that helped with setting the e-referral service, certainly for REGO, Vantage as it was called then, or NEC as it is now. And we set up quite a comprehensive e-referral system across Shropshire and Staffordshire. Now, the quality of referrals, this is a huge subject. There are different referral mechanisms and different dental specialities, and they all have their own nuances on how referral should be tailored. I cannot tell you everything, but what I can give you is some general tips and guides as to what to do and how best to refer. I could, in honesty, just do 1 2-hour talk on one dental specialty on its own, and even on one individual e-referral system. So what I have done, and what I will try to do, is stay fairly general. But I will try to give you some info on each of the different dental specialties too, and what should and should not be referred. Across the Midlands, there's no one uniform mechanism of sending referrals. This is why it is important to familiarise yourself with the referral pathway each time you start in a new practice or in a new job. Now that's really important. So one of the real important things about part of the induction of any new job, be it in primary, community or secondary care, is familiarising yourself. And it is the responsibility, after all, as a dental care professional, to ensure that the best care of your patient. So familiarising yourself with your local referral systems, your local referral pathways, and who your local referring providers are. It is imperative that all performers and providers, especially when starting a new job, do this, as it is different even if you're just working a few miles apart. It's surprising sometimes the differences between local referral arrangements to ensure that patient care is not compromised. So my aims and objectives here are fairly straightforward. It's just to tell you about what it is about effective and timely referrals, describe the efficient use of the referral services, and to discuss effective clinical outcomes for patients. Now, I will take a short interlude here and show you a little video. Just take a few moments, just a little bit of light humor really here. So why did I show that video? What it shows is just how desperate people can be. Now, although we take that in light humor, it is basically a joke. What it also did notice is at the end, you notice what they said, that they could save money by taking teeth out yourself. Now, obviously, there is no way we should be advocating this practice, but what it does highlight is at the end of all referrals, there is a real human being, a person at the end of it, with real feelings and real beliefs. So what is the purpose of writing and sending a referral? To improve patient care. Really important to keep that in mind. We can lose sight of what we are doing. And it is important that we always remember that there is a patient at the end of this all, and the importance of patient-centered care. Every time we write a referral, we don't just do it just with a shrug and think, oh, this is just another thing that we have to do, because I know I've been in that position myself as well, and that's what it does feel like. Oh, it's just another chore, something else that I've got to do. But put yourself in the position of the patient. There is a patient, after all, at the end of all of this. And it is important that we do take seriously the importance of making referrals and the importance of the effect that they have on your patients, and that timely, effective, efficient referrals are incredibly important to make sure that patient care is not compromised. Now, why we do what we do. If you were that patient and someone was about to write and send a referral for you, you would want that person to make the best and most appropriate referral for you. This ensures that that referral is sent quickly and reaches the right provider and is dealt with efficiently. This helps everybody and keeps the system working at its best capacity. We are all overworked and underpaid, but timely and high quality referrals are an essential and integral part of patient care and management. Important to remember that there is a patient at the end of all of this. So why am I here? Well, it has been noted by many providers, people who are receiving referrals, that the quality of referrals has decreased markedly, especially just after the pandemic. And there's just not enough information or attachments, photographs, radiographs being sent in as part of the referrals. And this has been a common theme on all the MCN meetings for all the specialties that I've attended, be it local or regional. And I can only really speak for the Midlands because this is specifically targeted at the Midlands. But all the MCN meetings I've attended, there is always a point at which we talk about the quality of referrals. That seems to be a standing agenda item. And there has been a tangible reduction in the quality of those referrals. There does still seem to be quite a lack of understanding about how to send referrals. And again, it is important for referrers, the people sending in the referrals, to familiarize themselves with the systems and patterns that are local to where they practice. I think there does need to be refresh on training on referrals. And again, there's been these repeat poor offenders, the same people sending the same poor referrals. Now, hopefully, I'm hoping some of which may be listening to this and will gain some insight and some knowledge and perhaps change their behaviors. But there does seem to be a small cohort, small group of repeat offenders who just don't seem to bother and just want to keep sending poor referrals in, regardless of how many times they may be told otherwise. And of course, if there are any questions about sending referrals, things like that, I will leave my details at the end, and please do get in touch if you have any burning issues. Now, mainly, I will say I use REGO, and I only really have a basic knowledge of FDS, but I am familiar with it and I have used it. But what you can see here is that across the Midlands, there are a number of different ways of sending referrals. So, and even now, people are still using letters and post. Now, this is specific really perhaps to private dentistry, although these days, fewer and fewer letters, but most people are now using secure email and of course, NHS email, hopefully. And again, certain specialties within dentistry are not covered by some of the algorithms around Vantage and REGO, and of course FDS, which is the dental referrals logo, which is the second one on the picture there. And because of that, they will still require either pro formas to be filled in online or things to be sent in by email. Now, because of this, it is important again to be familiarizing yourself with all the different mechanisms and specifically around the different specialties. And even locally within the Midlands, regionally, the algorithms are slightly different because the providers are slightly different in different parts of the Midlands. So, for example, the wider Birmingham will have a slightly different algorithm to perhaps Shropshire and Staffordshire, and also some of the services that are procured. So, for example, in Shropshire and Staffordshire, you can refer into Paediatrics and the CDS, which you can't quite do in other parts of the Midlands. Notts and Derby, of course, were the first part of the Midlands to set up an e-referral system. This was initially quite basic, but has subsequently been refined and expanded. And it was Shropshire and Staffordshire who currently have the most comprehensive e-referral service, which includes referrals for Tier 2 IMOS and Tier 3 hospital oral surgery, orthodontics, oral medicine, paediatric, and community dental services, as well as a 2-week referral pathway. What I am going to try and talk about, which cuts across all these referral systems. However, if you do have any specific questions, please do email me. If you are not using an e-referral system, for example, when sending restorative referrals, then I cannot stress the importance of using secure email to send patient-sensitive data. And of course, NHS email is the standard. So if you are going to use email, be it for private referrals or for NHS referrals, our advice certainly is always going to be to use a secure email system, and certainly the NHS email is the standard for this. Now, the algorithms and pathways that we use are not perfect, and we as referrers have an important role to play. Now, most of us do use FDS or REGO, but we realize it is not perfect, and the MCNs are really the vehicle to look at these pathways and changing them, which is why I can only encourage as many people as possible to participate in these MCN meetings. They are open, and there are MCN meetings for all these specialties. They are open to all performers as well as providers to attend. And commissioners, with the help of the LDNs, will have a final say in these DERS algorithms and pathways, but they can be changed and altered if necessary. It is not an easy balance to strike, of course, as in the algorithms are designed to challenge the referrer and give as much information as possible to ensure that it is an appropriate referral. The quality of referrals obviously covers many specialties, and different ones will have different requirements. The Midlands is a huge geography, and different parts will have slightly different algorithms, but the main principles will stay the same. Now, all the referral systems are based on and continue to follow these guides. These were much needed and fabulous effort from all those concerned. First time it is written in black and white what all dentists at different levels of experience should be able to do, especially the level 1 or tier 1 items. To be clear, level 1 or tier 1 mean the same thing. It's just some people tend to refer to them as level 1 or tier 1, but essentially means a normal general dental practitioner working in the high street. And I would commend all dental professionals to look and read through these carefully. This is one of the reasons I'm doing this talk to you all. We are getting referrals that are partly of low quality, but also for things that a primary care GDP should be able to do. These are important resource, And I ask all of you, please, if you have not done so, please read them. I will try to summarize what the salient points are, because I know a lot of what is contained in the guides may not be completely relevant to all of you. But this is just headline info, and there is a lot more to read than what I'm going to show you. Also, I'm only going to show you some of the guides. There are others. You can see and read them at the website that is listed at the bottom of the slide there. Or simplest thing actually is just to Google them. So dental commissioning guides, just Google that and they will all appear. So we'll start off with the first one, orthodontics. Now, please make note of what should be done in primary care. Level 1 or all primary care GDPs will need to triage their patients properly. Please do not just send everybody. Talk to your patients. The number of times I see a patient that do not even understand why they're there. Know your ITN scoring. Refer appropriately. Dentists have to work with orthodontists. Do not just refer and forget. Perform that basic orthodontic examination. Review the level of complexity and be familiar with what you can and cannot refer. And I cannot stress the importance again of familiarize yourself with what you can and can't do and your individual referral pathways. The e-referral service is there to provide a sieve to distribute patients to the best providers. That is why it's important to be as thorough and detailed as possible when completing the referral. The algorithms will guide the referral in different directions depending on the information that is available, which is again is why I cannot stress when you send a referral through whatever mechanism, just put as much information down as possible. Gone are the days of just sending, please see and refer. We need that information to be able to triage these patients. A lot of providers do run waiting lists, and it is important to be able to triage these patients so that if there is somebody who needs to be seen urgently, then they can be triaged appropriately. And if you look at this patient pathway, it shows just a representation of what can and can't be done through all the various levels. One thing I cannot stress is the importance of ensuring good oral hygiene in the patient. So when they're referred for orthodontics, there is no point referring somebody who has a very high caries rate or has frank caries or decay, untreated decay in the mouth, and has really poor oral hygiene. We as orthodontists will not start treatment on somebody who cannot look after their teeth. So cannot stress the importance of that enough. Make sure when you're sending a patient for orthodontics that their oral hygiene is completely resolved and it is as good as it possibly can, and that any restorative care that needs to be done has been provided. Now, if we move on to oral surgery, and again, this just shows all the tiers. Now, obviously, it is quite a busy slide and you can't see all of it, but what it does show again, and what I'll try and do is just highlight the important bits of tier 1. Now, you can see in the red arrows that are highlighted, these are what all general dental practitioners working the high street should be able to do. And look carefully. If you cannot do these things, then you definitely need to go on more training. So I stress again, extraction of erupted teeth including erupted uncomplicated third molars, and extraction as appropriate of buried roots, whether fractured during extraction or retained root fragments. Personally, I don't think the first point is obvious enough. It's not bullet pointed and it doesn't have its own significance. And personally, it should be bold and highlighted with flashing lights. I mean, it doesn't even get its own bullet point, and I think this is probably a printing or proofing error. But if you cannot take out simple teeth as a primary care dentist working the high street, for goodness sakes, go on some training, get some training done. This is a basic skill that all dentists should be able to do. Cannot stress that enough. And again, if we look at the patient journey that's based within the commissioning guides for oral surgery, it demonstrates all the things that can and cannot be done within all the different tiers and levels, 1, 2, and 3. And look where the referral system sits. Lots of pathways. GPs can refer to. But the guidance to GPs is clear that they should send the patient to a dentist first. And that has been stressed and stressed again, that GPs should not do things which are out of their competency. And certainly dentistry or dentally related problems, one of those things that they have been told, and the GMC is quite clear about this, that if they get a patient who has got a dental complaint, then that is something that should be sent to the dentist and should not be something that should be treated by the GP. And you can see the referral management system there, sitting there to try and sieve out what can and can't be done at level 2 or level 3A, 3B procedures for oral surgery. Now, if we look at oral medicine, again, look at what is said. And I think this is fairly self-explanatory and common sense. And it's more about recognition than treatment. So if you look at the level 1 conditions there, it is just being able to recognize that there is something amiss, that something's not quite right. That if there is something on the oral mucosa or the gingiva, or perhaps in the salivary glands or something else that does not look right, then that is something that should be referred up. And certainly initially, obviously, symptomatic care is fairly obvious about things like providing good oral hygiene information and, any prescriptions that may be necessary. An appropriate onward care to a provider and sending appropriate referrals, cannot stress enough the importance of that. Again, if you look at the patient pathway for oral medicine, relatively straightforward. Again, it shows where the referral management system sits, and it shows how it would be able to resolve some of the issues around distributing patients to the correct providers. And I know some areas do have IMOS services, and I know certain IMOS services are able to provide soft tissue interventions as well, and lesions, simple things like mucoceles and sort of polyps, things like can be removed in the IMOS. But anything more complicated, the referral system, the algorithm should be able to sieve that out. But one of the good things about using these dental e-referral systems is the fact that they have the ability to be able to redirect patients, up and down. So whether it's back to the referrer or up to tier 3, there is that facility within the systems as well. And then we go on to special care dentistry, and there are a number of different variables, so many different specialties out there. And what it's showing there is that while specialist dental, special care dentistry patients do receive the majority of their care in primary care, there is no reason why a general dental practitioner working the high street is not able to provide good routine care for most special care dentistry patients. And it is only in those exceptional circumstances, and there are different levels of competency, and we completely appreciate that, but clinical judgments do need to be made based upon knowledge, and appropriate referral should then be made to special care dentistry services in a timely manner. And again, if you look at all the different levels of care, what can and can't be provided, you can see there are many different things there that are possible. And again, looking through what level 2 and level 3 providers can provide, a lot of these are specialist or consultant led. And some of the algorithms there are based through with the help of the MCNs to be able to work out what you can and can't see and what you should and shouldn't refer, and what can quite easily be managed and treated in primary care. And if you look at the patient journey there again, you can see there are a number of different avenues there. It's much more complex than some of the other specialties, as there are multiple ways in which a patient can be sent in. And it's not just dentistry, but again, dental bit of the pathway stays the same. And you can see a number of different mechanisms in which a patient can be referred into special care dentistry services. Now, if we looked at pediatric dentistry, now again, please take note. It shows what the level 1 provider should be able to provide on the high street in general dental care primary services. So please make note. This is what is expected of primary care dentists. Do not just refer. Have a go. No one will criticize. So if you look at what it says, uncomplicated endodontic treatment of permanent teeth, routine extraction of primary and permanent teeth under local anesthesia, providing restorations of primary and permanent teeth with the use of local anesthesia where appropriate. It is important not to get de-skilled, and just because it's hard doesn't mean you do not do it. No one will criticize you for at least having a go, for at least trying. Do not just refer. Now, I appreciate not everybody has the same level of competency, and not everybody will be comfortable, but at the end of the day, you are professionals, and providing care to your patients is part of what your remit is as a general dental practitioner. And again, if we look at all the different things, the levels within pediatric dentistry, you can see there are other complexities and what you should and shouldn't be referred. There are a number of different things that you can refer for. And it is quite a complicated procedure, this, but again, the algorithms will help you, and if you ever have any issues, the MCNs are the best place to ask these questions, because they're a wealth of information and be able to help you with what providing information about what can and can't be referred. Now, if we move on to restorative dentistry and perio, now I appreciate this slide may be too small and too fine to read, but what it does do is talk about what should and shouldn't be done in primary care before referral is needed. Patient factors are huge, of course, in perio. And I appreciate that there are certain patients that just will not be able to meet those certain standards of oral hygiene, or just do not want to change their ways. They don't want to do all the things that are asked for them. And that is where the referral has to be managed correctly. And, the number of perio referrals that are refused or bounced back or sent back to the original referral saying they're outside of what can be done in either tier 2 or tier 3 providers, just shows that, there is quite a high bar at the moment for treatment for periodontal disease in specialist care. But certainly as dentists, we should be able to at least diagnose what we are seeing and what we can see within the periodontal health of the patients, and at least then provide a basic level of care that most dental practitioners should be able to do, and evaluating that using appropriate special tests, taking appropriate radiographs, and providing at least palliative periodontal care and maintenance, and providing the patients with information often talking to the patients is all that's needed, and making them aware of the issues, the importance of perhaps changing their habits like smoking alcohol, and also, of course, the importance of using and improving their oral hygiene. Now, if I go on to endodontics, and again, many different levels of care, and again, what it talks about is what can and can't be done. And if you look at what can and can't be done in level 1, you can see it's relatively straightforward, and it talks and gives some of the basics of what you should and shouldn't be doing in primary care. Again, there are certain things that you just cannot do in primary care, and it does give a pretty good idea of what you can and can't refer. But again, tier 2 or tier 3 services, if they're procured within your region, they have their own standards to which they have to see patients, and the bar is set very high again. So you may find a lot of treatments, a lot of referrals do get bounced back. Purely down to capacity, of course. There are capacity issues within providing these services as well. And then we talk about prosthodontics. Again, talks about what you should and shouldn't be able to do. And again, stress the importance that whenever you're sending a referral for some of these specialist services, the importance of having a stable oral environment. Now, good oral hygiene. All the caries is managed. There's no active disease, and if there is, then it's been treated, and periodontally they are stable. And obviously, patient's medical history does not preclude any treatment. And again, if you look at what tier 1 should be able to do, it's at least be able to diagnose and manage patients with uncomplicated prosthodontic needs. Now, as I mentioned earlier, there are other commissioning standards as well and other guides. So if you go onto that website or just Google it, you can see there are a whole load of other guides there. And what all this demonstrates is that what should and should not be referred, what can and should be done in primary care, and what all tier 1 or high street primary care dental providers should be able to do. Now, in the Midlands, we are fortunate or unfortunate, depending on how you look at it, to only have one dental hospital. This means that all tertiary referrals usually end up there. I know there is still the possibility of cross-border referrals, and this does happen, but what it does mean is that referral guidance is standardized, and there are no conflicts between dental hospitals as there can be in perhaps other parts of the country. Now, this is also where I qualified. So this is the old dental hospital, as you can see. This is where I qualified, and that's turned into a shiny, brand new, lovely building. And what I just sort of noticed recently is actually the sort of design, the outside appearance of it is very similar. It's still this sort of triangular sort of building. But the way they've designed it, obviously the new dental hospital, it looks very swish and very nice with all new windows, and a lot of it is glass, and fortunately not full of asbestos anymore. But if you follow the link there or type it in, what you will be able to see is all the referral in the hospital referral section, all the referral section for dental professionals, where all the different specialties are listed. So if you do need to send a patient in to the dental hospital, then all the mechanisms for sending that patient in are all available on that website. And again, it's very easily Googled, so shouldn't be too difficult. But again, just to give you an idea, the minimum requirements are all dental referrals. Now, the NHS number is now mandatory. All referrals must include this. Now, increasingly, referrals are being bounced back due to the lack of inclusion of the NHS number. So please do include the NHS number. Now, it is important, as you can mention there, is that as part of the referral, a lot of this is very basic information about patients' details, who their doctor are, your own individual details, which often I've a number of referrals I've received by email where it just gives the patient details without telling me where the referral has come from. It's just an email address. So I do, a lot of providers do need that information as well. But also, what do you want the specialist to do? Is it just advice only? Is it provision of part of a course of treatment that then the GDP will then complete? Is it just a single course of treatment? Is it current treatment and all future ongoing health needs as well? So be specific, add as much information as possible, adding that social history in as well about ease of access, any disabilities, communication, cooperation. And where would that patient prefer to be seen? Ask the patient. The number of times we get a patient in who does not even know that they're being referred to the dental hospital and actually quite surprised when they get a letter coming in. Inclusion of radiographs for many referrals is now also compulsory, and it is important that you make sure you use sufficient they are of sufficient diagnostic quality. And again, if they're not, that referral will be rejected. And again, make sure you've spoken to the patient, that you're sending them to the dental hospital. Tell them first, please discuss with the patient where they would prefer to be seen. Local referral centres for orthodontics or oral surgery should all be able to provide a similar standard of competency of treatment as well as the dental hospital. Now, some patients have been seen at hospitals and the dental hospital, and after quite a long wait for assessment, and then decided that they would prefer to be treated locally. So that's why it's important that if you're going to send somebody a long way away, tell them first. The dental e-referral system gives a lot of primary care providers and then a second list of hospital providers of the patient if the patient needs to be referred on for consultant care. Now, these do include waiting times and distance from the patient's home as well. And it would be great if dentists would discuss with their patients their preference before making the referral. In e-referral systems, there will be drop-down boxes and other information to ensure that the referral is directed properly. And it is imperative all these fields are filled in correctly. Now, again, I talk about radiographs. All the e-referral systems, both the ones in the Midlands, be they REGO or FDS, dental referrals, both of them have mechanisms for uploading radiographs and photographs. Also, when sending emailed referrals, please ensure you attach all the relevant radiographs and photographs. Now, one additional benefit of the REGO system has gone one step further with the facility to upload photographs from a smartphone. So you don't even need to have them uploaded onto your computer. You can actually use a smartphone, and who doesn't have a smartphone these days? And there is a guide included in the REGO system to tell you how to do it. And again, photographs. They paint 1,000 pictures, and both the systems again have very simple, easy ways of uploading photos and radiographs. And I cannot stress the importance, especially within oral surgery, of just taking a picture and again using your smartphone. Nothing too difficult about including a photograph of the lesion. And the quality of dental photographs has to be taken, has to be good. And again, smartphones these days have excellent cameras, and the quality is perfectly good enough to upload with referrals into any of the dental e-referral systems. But of course, if you do have access to high quality dental photographic equipment, then please use that instead. And of course, any of these systems, when you're referring through REGO, they are totally compliant with GDPR and patient confidentiality. Now, why are referrals rejected? Now, this is an easy one to answer if you're listening to all the things I've just said. Now, if you followed those minimum requirements, referrals will not be rejected. Again, making sure that all the information added, and I suppose this is especially important if you're sending emailed referrals in, make sure that you had those initial minimum requirements of referrals that I mentioned a couple of slides ago. Use the free text boxes to provide additional information. That really helps us as providers because as again I said earlier, we triage referrals, and any additional information that you provide will help us to triage those referrals into either our normal standard waiting list or the urgent treatment waiting list. And attaching appropriate and diagnostic radiographs and photographs cannot again stress the importance of that, and they have to be of diagnostic quality, of course. And be specific. Make sure that what you have stated, that what you're referring for. Again, more perhaps relevant when you're sending paper referrals. You know, this thing about please see and treat, that has completely been taken over now. We need a lot more information. Referrals will be rejected if there isn't enough information provided. And follow the referral criteria. Know what the local guidelines are. Look at the commissioning guides. They will provide you with what you can and cannot refer, what a level 1, 2, or 3 provider will be able to get, or what is expected them to be able to carry out. And why are referrals rejected? Well, these are some of the reasons that are stated for restorative dentistry, and it's relatively straightforward. What it does do is highlight some of the important features and know the guidelines. Restorative dentistry especially has a problem. There are numerous referrals that are rejected because they fall into the level 1 criteria of what a normal high street dentist should be able to do. Look at the commissioning guides, look at the guides that are available on the Birmingham Dental Hospital website as well. It lists all these, and you know, if any of these apply, then there's no point sending the referral in. As I mentioned earlier, there are mechanisms for uploading photographs into all of these dental referral systems. Now, I'm not an expert on FDS, this is dental referrals, but this is what the screen looks like. And it may be slightly different in different formats and on different web browsers, but this is what it looks like. And you can see there, very straightforward. If you're uploading radiographs, click on there, and if you've got other materials like photographs or documents, then you click on that box and that will upload those documents for you. Very, very straightforward in FDS. And again, in REGO, it looks slightly different, but again, with REGO, there is built in the facility to upload photographs directly from the smartphone as part of a referral. And this is especially useful for uploading pictures of plain radiographs. Now, once a referral has been initiated, you can see there is a button there, the add button, and that's how you add those extra photographs and radiographs in. And if you want to then send it from mobile, you click that tab at the top there where it says from mobile. And what it does, it provides you with a PIN. And on your mobile device, what you do is you go to that website there. So number 1, it says, please go to http://ref.management.mobile. And what that will do is take you to a web page, which you can then actually put on your home screen as the REGO uploader. You put that pin in and it adds the photos straight from there. Very, very straightforward. And this is what it looks like on your phone. You enter that pin and it lets you have the and it uploads that photo for you. Now, what I want to just talk about is just some of the things that just to give you some examples of some things that we have received, and some of the poor practices that are out there in primary care. And these are real radiographs sent in by GDPs of real referrals received in the Midlands through the various referral mechanisms, and this is through electronic referral mechanisms. These are not made up. And as you can see, if you're going to send in a radiograph like that, that is completely unacceptable. Not diagnostic, nor meeting any national guidelines. You can't even make out the teeth there. And again, if you look at this, this is a real referral that was sent in as part of a clinical record. And you can see what's actually written there. It says, without adding an X-ray, I was unable to upload a photograph. So what he's done, it actually says there, this is my brother's broken finger. So he's actually said he knows that he shouldn't be doing it, but he's done it anyway. Now, be warned, if you send inappropriate attachments or incorrect information, this is committing an offence. Referrals are part of the clinical record of the patient. This is patient confidential data. If you're adding inappropriate referrals as part of the clinical information of that patient, that then is attached to that patient record indefinitely. And all these things do get stored and logged. And commissioners are told about these things. I said earlier, repeat offenders will be talked to and are completely unacceptable behaviours. Other things, late referral of ectopic canines. Now, this is a huge problem, and not just in the Midlands, but across the whole country, and perhaps of greatest concern, and especially during the pandemic, because there has been a backlog of referrals and there's been lots of patients that may have ectopic canines that may have been missed. So if canines are referred late, there is a much greater risk of root resorption of adjacent teeth, and treatment may become more complex. Ideally, referral and palpation for canine should take place between the ages of 9 and 12 years old. And if you cannot palpate the canine and is unerupted, it's very important, take an X-ray intraorally. If you don't have an OPT, use an intraoral film. And if there is suspicion that it is a problem, then make sure you attach that radiograph with that referral. Monitor and check your patients. If a patient does not have their maxillary permanent canines by the age of 12 years old, look for them, find out what's going on and refer accordingly. All referrals are triaged, and I say this again, according to treatment need. Providers can see patients urgently, so something like this, if picked up, if written correctly in the referral, can be triaged and seen much more quickly. But providers can only triage referrals on the information that is provided. And that is why I stress again, please do send all relevant information and include it with the referral. Early referral of class 3 cases. Most class 3 cases will not be seen until the patient is in their late teens. And referring early just clogs up the system. So if you do have a class 3 case, don't send them in their primary dentition. And this has come directly, this ask has come directly from the Midlands Orthodontic MCN. This must be a problem because it's come directly from those providers. There is no point, and I appreciate, when you see a class 3 case in a very young child, you're almost itching to send that referral in, but they cannot be seen or treated until most of the growth has been done, and especially all the adult teeth have erupted. So please don't send these in early. Wait until they are finished growing and then send at that point. Poor referral practices. Incorrect recording of severity of overjet, reverse overjet, or inconsistent or non-existent cleft palates or craniofacial disorders, etc., are some of the things that are written into referral practices just to try and beat the algorithm. This is just to try and get the patient seen more quickly. They do not help the patient to be seen earlier. And again, all they do is just clog up the system, because when the patient is seen in an emergency, all that's going to happen is that patient is then put back onto the waiting list or bounced back to the original referrer. It just clogs up the system and it's just wrong. Some of this may be just education though, but some practitioners do admit that they have falsely ticked a box to say that the patient has a cleft palate just to get them into the dental hospital. Please remember again that this is part of the clinical record. Incorrect information on referral to expedite a referral is unacceptable. One of the other really big problems, really poor practices, is multiple referrals of the same patient to different providers in the same locality. Now, a lot of these dental e-referral systems do flag this up, but there is an override, and referrers are wise to this and they use that override button. But don't forget, the systems do flag this up. And commissioners are aware of this. This practice just leads to unnecessarily increased waiting times because the same patient is on different referral systems in different on different referrers, and all it's doing is increasing waiting lists, artificially in this case. Also, please do regularly check your dental e-referral service at least once a day or at least once every other day and respond to queries. One of the beauties of having these e-referral systems is because it does provide a one-to-one dialogue between the referrer and the providers, which we very rarely have. And it's very important that if a query or information or request for further information is being sent through the e-referral system, that it is responded to very quickly. If a referral is rejected or returned for more information, dentists should respond immediately. And all it's doing again is just resulting, if dentists don't do this, is referrals just sitting in the system and the patient's left hanging. And there are a number of very long waiters where they're just sitting in the system for months and months and months, waiting for dentists to reply back to queries that have been sent to providers, from providers to referrers. Now, one of the things I will highlight is that certain areas now, there are tier 2 or level 2 oral surgery services, and they have, some of them are under procurement, some of them have been procured already. And the idea of these is to unblock some of the oral surgery waiting times and to make it quicker and easier for patients to be seen. Now, in some of these now, there is also the inclusion of sedation for the first time as part of the e-referral system. And I think this will be a game changer for a lot of patients locally, and I cannot see it being anything other than to improve patient care. And this is one of the big things, I think, hopefully, that will get rolled out across the wider Midlands. And I'd say certain parts of Midlands, this is happening already, but being able to refer using dental e-referral systems for sedation into some of these tier 2 IMOS providers is really beneficial and will hopefully improve patient care, reduce waiting times. Now, I'm just coming to the end of my talk here. I'd just like to say thank you for listening, and hopefully I've kept you awake during all of this, and hopefully what I've done is covered off those objectives from aims and objectives that I mentioned right at the start. The importance of effective and timely referrals of patients, the efficient use of referral services, and how this improves the clinical outcomes of patients. Now, you should all now be able to list the essential requirements of all referrals, recognize common reasons why referrals are rejected, and identify and attach suitable radiographs and clinical photographs and other attachments as well, referral letters from other clinicians, other documents, letters from GPs, to ensure a detailed and appropriate referral is submitted. So please, again, remember, there is a patient at the end of all of this. And no matter what we do and say, improving the quality of all referrals, it can only be greater and better for the improvement of care that we can all deliver to our patients. Thank you for listening. These are my contact details. If you do have any queries or questions, then please do get in touch. More than happy to answer any questions that you may wish to have. Thank you for listening.